Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibuster and Fine Print, AMGA's public policy podcast. As always, I'm your host, Chet Speed. I'm with the expert crew. To my left is...
Oh, it's me. I'm back from outer space.
Was it a grand time?
It was a great. Honestly, I really liked jury duty. I'd do it again. I mean, I might have to in 2 years. So it's good to be back, though.
Jamie Miller, Ambassador Goodwill for AMGA.
Hi, everybody. I'm Daryl Drevna, the Senior Director of Regulatory Affairs.
Alicia Sawyer, Government Relations Assistant.
Outstanding, and thanks for the podcast. No, okay. We have actually a very meaty thing to do today. It's regulatory wise, so that's why I have a 2-page outline of very in-depth questions that Daryl drafted for us to go over. But before we do that, the question of the day: what is your favorite season as we hit summer?
It's always gonna be fall for me.
Fall.
I love the changing leaves. I love a sweater.
Yeah.
I have a standard wardrobe look. I have a color scheme. It's the best. So
Outstanding.
Yeah, I like fall too. I like greens and I like wearing corduroy. And I used to like wearing all the pinks and stuff in the summer. Then I realized that it doesn't work with my skin tone. So
A valid concern.
I also like fall, but it's because football season kicks off.
there you go. That's super
Yeah,
manly.
yeah.
Football.
Football.
I like that too.
I'm from Florida, so I like summer.
Isn't it summer all the time?
Yeah.
In Florida.
And I like that. I like being warm. I like feeling the sun on my face.
So climate change is really working for you.
I guess you didn't have
It
to
is
rake
Florida.
leaves as a kid because there's no leaves.
No, I never had to rake
Oh, that's pretty sweet.
Oh, that terrible grass, though.
Oh, yeah. It would like pop balloons if you dropped one
I
on
remember
it.
that stuff.
Well, how about you, Chet? What's your...
Oh, right.
yeah.
Oh, I probably have to say spring because that's lacrosse season.
Oh.
So, speaking of which, I have a story about that, but that'll be later. Okay, so let's get into it. Oops, I just clapped and Mike grimaced. Of course, I will say this. Mike turned off the AC. It's about 85 degrees in this room, so it's very hot and uncomfortable. Thank you, Mike.
Yeah,
Feels
Alicia
like
likes
summer.
it. Yeah.
Oh, that's
Yeah.
well. We have a welcoming environment at AMGA. Okay, so today, this is what Daryl wrote for me to say. We will discuss the significance of President Trump's Executive Order 14192, unleashing prosperity through deregulations. We're going to talk about its implications for Medicare and CMS's separate request for information around regulatory relief. So let us start off with some background on this executive order, or also known as an EO in the trade. Alicia?
So unleashing prosperity through deregulation. The EO is looking to reduce private expenditures by reducing costs associated with complying with federal regulations. And a big way, and the primary way that the EO is looking to do that is through reducing regulatory burden and the costs associated with that. And so they are looking to remove 10 regulations that are already in practice for every one newly proposed regulation by agencies or departments.
Wow, a 10-to-1 deal.
BOGO.
That's BOGO?
Buy one, get
10 free.
10 off.
Okay. I thought it was a Gen Alpha thing. Okay.
No.
Okay, so I won't use BOGO with
That's
my...
a Walmart thing?
It's about sales. Everyone loves a good deal.
Okay. Yeah.
BOGO. Good. Yeah, fantastic. All right. So moving beyond BOGO, this EO, what is the reaction on Capitol Hill about this? There's been a lot of EOs out there. Some have been favorable, some have been unfavorable. What's the Hill reaction?
I think it probably depends on which party reaction, but I think in general a bipartisan perspective is that that members of Congress want less regulation in any sector as long as it protects people. And I think from a Republican perspective, we've been hearing a lot from Ways and Means Committee, GOP Dot Caucus, that they think there's a lot of unnecessary regulations that are impacting the patient, like making sure that things with like the 3-day sniff waiver and other stuff we'll talk about later, impacting patients' access to care. But then there's other controversial regulations like the nursing staffing ratios that becomes more of a labor union issue and things like that. But I would think from the Republican perspective, they've been reaching out to us for years on this for regulations, for deregulations to suggest. And I think just to break it apart a little bit more, if you revoke the regulation and it doesn't cost any money, Republicans love it. If it costs money, that makes it more complicated. So I would say we've, at least from my conversation for the past 5 years, we have a running list of regulations we suggest to members of Congress that they should potentially eliminate.
Yeah.
Which we'll get to.
Oh, yeah.
Yeah,
I'm sorry,
it's been going around, like Jamie said, for quite some time. I mean, even throughout the first Trump administration, you had the Red Tape Relief Project. And I think there can be really great ways to deal with like regulatory relief in bipartisan manners. I think Democrats are all sometimes looped into being like anti doing some of these, but I think especially in terms of certain healthcare regulations and certain things, Democrats actually reach out and ask these questions as well. I think right now though, when you have a 10-to-1 proposal, I think it's a little bit difficult when you're thinking about for Democrats to kind of join on board with this, when you're thinking about things like Department of Energy, you're thinking about ag regulations, you're thinking about more consumer kind of protection things. Democrats are going to be a lot more vocal on it, particularly because this is coupled with all the cuts that have already gone on with the Trump administration in terms of like letting people go from regulatory positions. So I think it's a little scattershot right now how Democrats could come aboard on this. I think they're really stressed.
Okay, and so Democrats are not as BOGO as ours.
No.
Okay. I'm going to use this term BOGO all day long.
I have a feeling.
No,
yes.
What if I started?
This is very exciting for me at least. So you have the EO, but also there's the CMS request for information around regulatory relief. And so, Jerry, why don't you tackle that real quick?
Sure. So what CMS is doing, basically, they've gotten their marching orders from the Trump administration through this EO, and one of the ways they're going to sort of honor that request is through this RFI, request for information. And what they've done here is put out this call for a response on, and it's really, really open-ended. If you take a look at the actual questions,
Which
I have in detail.
Sure you have.
Right. And we're actually going to file our comments, as we speak on this. And it's looking at everything from, are there conditions of participation in the Medicare program that are causing problems? Are there documentation requirements that are unnecessary? Are there overlapping regulations that cause confusion? And it's not just the regulatory level. They're talking about sub-regulatory guidance, memos, anything that's coming out of these agencies that could be conceivably or even remotely considered regulatory or administrative burden. They're interested in hearing from the stakeholder community on, can we eliminate these? Can we waive these? Can we streamline these in some way, shape, or form? And that's what our response hit on.
Someday we're going to actually videotape these podcasts, and I wish we were today, because you should have seen Daryl's face when he said sub-regulatory guidance. It just lit up like no one's business. It's very exciting to see.
It's you have to. What you want is to find something you really love to do.
SRG, sub-regulatory guidance.
There we go.
All right, well, fantastic. So I guess the RFI is broken up into a few things. I guess the first one is sort of streamlining regulatory requirements. What are we saying about that? Lisa, you want to take the first shot at this?
Yeah, so we've got, as it's been mentioned, some rules, regulations proposed that we think could be removed and would provide a massive benefit to the healthcare system. And one of these is the 3-day stay requirement for skilled nursing facilities and care. This rule was enacted in 1965. So that says something in itself there. I mean, think of all the things that have changed since 1965 to now. And medicine and healthcare has majorly changed. And so the minimum 3-day inpatient hospital stay is just no longer aligned with contemporary clinical practices. And CMS actually tested a waiver removing the required stay for certain ACOs, and there was a massive improvement in care seen.
Right. And that's great. I do know that in 1965 I was born.
I was wondering. I was like, "Oh, this could get sticky." I was like, kind of had my shoulders up a little bit.
Vintage things are trendy now. So
Wow. So we're using
Well done.
vintage.
Major evaluations are coming up in case you all were interested.
I would add on 3-day sniff waiver. There's been every Congress has members of Congress who introduced legislation to repeal it. During the pandemic, I know you mentioned ACOs don't have the rule, but during the pandemic, CMS suspended the rule as well because they wanted people out of the hospital during the pandemic. So there's definitely a track record here that repealing that 3-day would actually help patients.
It would.
Yeah. And I think that's one of those things that makes intuitive sense both for providers and patients. It's something you can see. I remember talking to like my grandfather when he was in the hospital. It's like, make sure you stay 3 days. And like the charge nurse was like, how could you possibly know that? I was like, oh, trust me. I've read the rule. But you have those big ticket items like that. And then you can like our response and what CMS is interested in can get a little bit more granular. Something like, the documentation requirements for TME supplies, right? And this is, do we really need a physician's signature to sign off on every piece of DemiPost equipment that goes out the door? I hear a lot from our members about how this just creates this slowdown in the process and it can disrupt care. One of the examples that comes up a lot is the need for a face-to-face visit to, refill supplies for continuous glucose monitoring. If you've got a controlled diabetic patient, do you really need a face-to-face visit to have a refill? And so we're like, let's take a look at where you need a physician signature and what can be done automatically to make sure patients get the supplies they need in a timely fashion without really slowing things up. Slowing things up, I think, would be the next one, would be prior authorization. We have a lot to say on prior authorization. I know Lauren's done a lot of work on this too, both from the Hill perspective and for the regulatory side, we're trying to get CMS to eliminate, to the extent possible, any sort of prior authorization requests in the Medicare Advantage program because it's simply slowing things down.
And, as we talked about earlier, this is one of those bipartisan issues that both Democrats and Republicans really get together on. It's like a hot girl issue on the Hill, but it is kind of difficult to get something passed like this. During the Biden administration, there was a lot of regulatory work that was done in order to sort of reduce these things regarding prior authorization. But this strengthening it would, I think, make it a lot easier for Democrats to come on board if there is some sort of bipartisan kumbaya that comes back around again. I don't know when that is going to be, but possibly. And so I think when you're looking at, particularly when you're hearing constituents talk to members of Congress about this and seeing all the things that have been happening in the insurance industry, having these conversations, I think, is a lot easier now because the public is more informed about what prior authorization is. So it will be interesting to see what the Trump administration continues to do on this issue.
All right. That sounds good. I know prior auth is one of the biggest issues for our members. Many are under Medicare Advantage plan contracts. Well, speaking of things that bother the members, obviously reporting and documentation is a humongous issue. We've been hearing for years about the quality reporting burden on members. I do recall one member saying that they had to submit 500 measures to both federal and commercial payers. And there's been, AMGA's been on this for several years now. So what are we thinking on that?
Right. It was nice to see CMS have another opportunity for us to weigh in on just the burden and the unnecessary reporting of quality measures. And, they are starting to do a lot of work in this area. They rolled out their universal measure set 2-3 rulemaking cycles ago in the Medicare Advantage program, and it mirrored a lot of the work that AMGA did back in 2018 with a value measure set. And what that was a set of 14 value-based measures that were more outcome versus process-based. We had a committee of AMG members. They developed these measures. And if you're interested in transitioning to the value and really measuring the type and the quality of care that are being provided under these types of delivery systems, these are the 14 measures that you really need to focus on. To Chet's point, a lot of our members are reporting that depending on what program you're operating in, whether it's MA or MSSP or a commercial payer, you can have up to 500 plus measures you're reporting. And that just it's a time suck and a cost that is taking away from the care our members are able to provide.
Absolutely. That would be if we could reduce that, that would be a great win for the members.
Absolutely, yeah.
good luck on that.
It would just, yeah. Been working on it for a while, so a little bit at a time, and I think that little bit of time is really sort of the key to this whole enterprise. And I think we're making some progress on another issue of ours, and that's telehealth. CMS issued a number of waivers coming out of the part of the response to the COVID pandemic, and we really learned how important and vital telehealth can be both to our members and our patients. And writ large, you've got the geographic and the originating site restrictions, but then there's these more granular issues like the ability to prescribe controlled substances via telehealth. And I know the Hill's taken a big interest in this as well.
Yeah, and I think when you first talk about waivers, telehealth waivers, when it comes to site of service and geographic, those are comprehensive and also cost money according to the Congressional Budget Office. But when it comes to these DEA regulations coming out and allowing people to get access to controlled substances, it's weird because it's been done on the regulatory level, and from my perspective, that means that it doesn't actually doesn't have a CBO cost score. And we've been pushing this for years. Actually, there's two members of Congress who've been champions of this. I think last October 2024, Doris Matsui and Buddy Carter, who are very high-ranking officials, Republican and Democrat on Energy and Commerce Committee, have been writing out to DEA saying you need to codify these requirements because people need access to care. And I think it's good to know that from a regulatory perspective and budgetary that it's not costing more money to the government, which means that it's not being overutilized. It's the right people are getting the right care at the right time, which is what AMGA stands for.
Yeah. All right, great. And Alicia is pointing at me saying that our time is rapidly coming to a close.
Oh, no.
But there's one more thing. One more. And I follow your outline.
Did you pop this balloon?
What's that?
Yeah.
No. The issue of overlapping regulations between fee-for-service and other healthcare programs, which is a big issue because we have members in fee-for-service, we have members in value and MSSP. So this is
it's interesting because as someone who lives in the regulatory world, it's easy for me to pick one binder off the shelf and read it and then pick the other binder off the shelf and read it. But I'm not trying to deal with, delivering clinical care. Lauren's laughing at me because it's like
binders.
He literally does pull binders off his shelf.
One day I'm going to open a bookstore and it's going to be fantastic.
Yeah.
Everything's going to be
It'll
that
be a
Federal
profit
Register
winner.
font. Yeah, all of DC regulatory world's going to descend, all four of us. It's going to be great. And we'll have to, we're all introverts, so there will be no overlapping.
Sorry.
Yeah.
No eye contact.
Yeah. So, I'll have the morning shift and someone else will come in. Anyway, information blocking. Big problem. And one of the issues we're having with this is you've got a bunch of different agencies who are responsible for implementing these requirements. You've got CMS, ONC, the Office of Civil Rights, all have a piece of this, so it can get really convoluted very quickly. And if there's a way for one agency or one office in those departments to sort of take the lead and handle this, that would make a whole lot more sense. One from a regulatory guy standpoint, one voice makes it easier, but then I'm able to transmit or provide those details to our membership a whole lot easier, and they'll understand what it is they can and can't do. So let's streamline the rules so everyone understands what exactly is information blocking, who's going to be held accountable, why they're going to be held accountable, and how we can, be good actors and make sure patients get the information they need and other providers get the information they need in a timely fashion.
Sounds great. All right. Any final thoughts from the team?
Can't wait for that bookstore to open. Really excited about it for you.
Yeah. I know in right here in Old Town there was the romance Friends to Love.
Lawrence to Friends.
Yeah. So right next door, right? Right next door.
Serve bad coffee there.
Is there a such thing as bad coffee? Maybe. But, I think CMS is really interested in this issue of deregulation. I was talking to the Deputy Administrator, Kim Brandt, the other day about this, and she's going to speak to our Board of Directors.
Did you hurt that mic when you dropped it? Or?
Oh, yeah, boom. Look at that. He's plugged in. Thanks, JB. No, yeah, no, but she is seriously interested in hearing from our membership about this. So we're going to file it. We filed our comments on this, but I think CMS, the senior leadership, is going to be very interested in hearing more from our members about this and having our members come in and talk to the folks at CMS about what those pain points are and what we might be able to do to address them.
All right. That sounds great. A great opportunity. Glad you're on top of it. Thank you, team, for a very good panel, and hope everyone has a good day. And that's it from AMGA. Thank you.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.